am the lead next generation editor for the Aesthetic Surgery Journal. Welcome to our 4th live journal club, which is held every first Tuesday of every month at 8 p.m. I would like to thank the ASJ staff, in particular Phaedra Kress, who worked very hard behind the scenes to organize this event for the NGE every other month. I'd like to introduce the author of this article, Dr. Mohammed Alghoul, who is an assistant professor at Northwestern University. Dr. Alghoul completed his general and plastic surgery residencies at Cleveland Clinic, microsurgery fellowship, and then did an aesthetic and oculoplastic fellowship with Dr. Cardner. He specializes in cosmetic surgery of the eyelid and face in his practice in Chicago. Today, he is sharing his expertise in this area in this featured article. And tonight, we have the opportunity to further get insight into an area of facial aesthetic surgery that can be very challenging. So I'd like to start off with a few introductory slides from Dr. Alghoul, and then we can open it up for some questions. So for those of you who are joining us via video on Zoom, please type your question into the chat box at the center bottom of the screen, and it will go to either Phaedra, myself, or the whole group you can designate. If you are joining us on audio only, please email your question to Phaedra, that's Phaedra @surgery.org. And for those of you who can't join us tonight, this journal club will be recorded and available on the ASJ website. So during the session, Phaedra and I will be curating questions, so we may be looking down at our phones as the session continues.
Handy.
I'm sorry?
No, we've got them handy. We're ready to.
Oh, okay. And also, as a reminder, this is a CME article, and participants can go to the ASJ website, take the questions associated with this article, and claim CME credit. So with that, I'd like to please have the slides, Phaedra.
Okay, Dr. Alghoul, over to you.
Okay, great. Thank you, Dr. Wu, for the introduction, and thank you, the ASJ, for the opportunity to discuss the article. So, yeah, blepharoplasty. This is a CME article on anatomy, planning, technique, and safety. And go to the next slides, please, Phaedra. So, you know, obviously the article is kind of a comprehensive article on blepharoplasty, both upper and lower blepharoplasty. Starts with discussing surface topography, which is kind of one of the most important aspects of understanding really the surface anatomy. You know, looking at the periorbital area in general, I like to look at it in terms of generally speaking line and the intervening spaces. Starting with the eyebrow, the upper lid, lower lid crease, and both the lash lines, the upper lower lash line, and then the lateral orbital adhesion, and the C-shaped fullness from the lateral brow. Next slide, please. And then, most importantly, not only looking at attractive, unattractive features, but also comparing the youthful look and the aging face. And this slide is also a very important slide because it goes over the different aspects, basically, of what constitutes a youthful look compared to how do we age. And as you can see, the signs of deflation, the fullness. That actually disappears with time, and then you start getting accentuation of certain lines like the tear trough and loss of projection. Here, this is a slide that shows basically a two-dimensional periorbital anatomy, and it's very hard to kind of really show the three-dimensional anatomy in one illustration. So did a great job just showing us basically the key, anatomic landmarks in the periorbital area. Next slide, please.
Dr. Alghoul, can you hold on for 1 second? Can I ask everybody to please mute their mic because we're getting a lot of background noise and we're having a hard time hearing you. So, and then we'll open up the mic for question and answer. Thank you. Okay. Over to you.
Perfect. So, the article also has, several intraoperative pictures trying to show, the anatomy. This is basically an upper blepharoplasty, just showing clearly the nasal fat pad and the central fat pad. The next slide, please. And this is also an important concept. Basically, understanding when you're doing a lower blepharoplasty, when you're going on a preseptal plane compared to a postseptal plane. So when you're on a preseptal plane, you have a complete different visual compared to when you go postseptal. So preseptal, you're looking at the septum, you're opening the septum, and you're clearly seeing the central fat compartment and the lateral fat compartment in this picture, and in between is the arcuate expansion of Lockwood ligament. However, and you see this obviously if you're going in the skin muscle flap technique or a transconch technique that goes preseptal. Next slide, please. If you're going transconch, however, what you're going to see is going to be completely different, and that's going to also important. And this is why certain people are more comfortable with a transconch approach compared to the preseptal approach, because as I said, the anatomy that you're going to see is different. So here you expect to see the inferior oblique muscle. You expect to see the central fat pad, the medial fat pad. So the medial fat pad is easier to visualize, transconch, while the lateral fat pad is more easier to visualize, the preseptal plane. Next slide, please. We also kind of showed, that there are several pictures in this article showing, different steps of certain procedures. So this is basically showing an example of the skin muscle flap technique, the lateral orbicularis suspension, trimming the skin. And then the left upper corner showing, blending or redraping the fat, blending the orbital fat with the SUF. Next slide. And this is a cross-sectional illustration showing basically the different planes used. So skin muscle versus the transconch approach. One of the things that kind of wanted to emphasize here is different people use different terminology as far as arcus marginalis and orbicularis retaining ligament. So surgeons who use primarily the transconjunctival approach, you tend to say release the arcus marginalis, because that's really what they encounter when they're going transconch. Especially if they stay post-septal. Now, surgeons who do the skin muscle flap technique, on the other hand, they tend to say, releasing the orbicularis retaining ligament, because this is really the structure that they encounter. They typically don't release the arcus, they would release the orbicularis retaining ligament. At the end, they both will, have the same effect or same result. And, that's typically done in two situations. One, whether you're, suspending the orbicularis, and also for redraping the fat. Next slide, please. So this is an example of a pre- and post-operative, picture. This is a younger patient who had a transconjunctival blepharoplasty with fat redraping and lateral canthopexy. This is the patient who, the video, the transconjunctival blepharoplasty video in the article. This is the patient that the video was on, and this is her long-term results. Next slide, please. This is an upper blepharoplasty, and this is the case or the patient who had the marking done in the article as well. So there was an upper blepharoplasty marking, and this is the patient that we did the marking on. This is her results afterwards. Next slide, please. So these are some case examples. This is a younger patient, a relatively younger patient who had a prominent fat bag, prominent tear trough deformity. She also has a negative vector. So this is also a patient that, right now I would probably do a transconjunctival approach, but in this particular case, I did do a skin muscle flap technique with lateral canthopexy, fat redraping. Next slide, please. Another patient, upper lower blepharoplasty, also a skin muscle flap technique. Next slide. Older patient. So brow ptosis, upper and lower lid, dermatochalasis, not much of a fat, a prominence, fat bag prolapse or herniation. So she had a temporal brow lift, upper bleph, lower bleph. It was a skin muscle flap with fat grafting to blend in the eyelid big junction. And this is her results 8 months later. Next slide. Another patient who has a favorable anatomy, positive vector. She's bothered by the wrinkling in her lower eyelid, and not much of any fat prolapse or fat herniation. She also had a skin muscle flap technique and fat grafting of the eyelid cheek junction. Next slide, please. And this is another example. This patient had a prominent fat bags, tear trough, a lot of crepey skin all the way down to the infraorbital rim. She had lower lid laxity. Distraction was about 10 millimeter. So in her situation, I decided to do a transconjunctival approach with fat redraping, elevated a skin flap all the way to the rim, and then did a lateral canthoplasty and upper lid blepharoplasty. And this is her long-term results as well.
Well, thank you, Dr. Alghoul, for summarizing your very comprehensive article and showing us your beautiful results. And I know that people in the audience probably have questions for you. While people are kind of gathering their thoughts and thinking about their questions, I do have a question for you to kind of stimulate the discussion. And one thing that might be helpful for the audience to know is, how do you choose between doing a pre and post septal approach for your lower lid blepharoplasty?
It's a great question. So, it depends, I guess, on the, first of all, what type of blepharoplasty are you doing? If you're doing a skin muscle flap blepharoplasty, so then, normally you would go in a preseptal plane. Now, if you do a transconjunctival approach, depending on where you make your incision on the conj, you may get yourself into a preseptal plane or a postseptal plane. Now, if I'm just removing fat, simply just doing fat removal, no fat redraping, I will most of the time do a transconjunctival postseptal, because you're going to have direct access to the fat. You leave the septum alone. You're not really releasing arcus. So that's basically pretty straightforward. Now, if I'm doing fat redraping, I have really, alternated between both techniques, and I think both of them, are totally fine. There has been a comparison in the literature, I think, Dr. Guy Masri, who did, comparison between a preseptal and postseptal, and basically looking at whether, the tear trough correction was better with a preseptal. And I think there was a slightly improved correction of the tear trough, when you do a preseptal approach. So when you're doing a preseptal approach, you release the orbicularis retaining ligament. When you do a postseptal approach, you're really releasing arcus, and you're elevating the muscle in a subperiosteal plane most of the time. So both of them are basically valid technique. I think it just depends mostly on the comfort level and the type of exposure that you're trying to accomplish. So if you really have a localized fat bag that is mostly medial and central, and there is not any skin excess, and you're just redraping that particular area, I think a postseptal approach works very nicely.
Okay, we have a question in from Dr. Thanos Pappas. Are there any indications for tarsorrhaphy post-blepharoplasty?
Yes, that's a great question. So the only time I do a tarsorrhaphy, and I know there are surgeons that do tarsorrhaphy routinely. The only time I do a tarsorrhaphy, a lateral tarsorrhaphy on the table, if the patient develops chemosis on the table. So by the end of the procedure, if I see that the patient has developed chemosis, this is the only time when I would actually do a lateral tarsorrhaphy, because I know this is going to get worse. Some surgeons going to use a tarsorrhaphy for splinting purposes, for 4 or 5 days. However, the canthopexy, that's what the lateral canthopexy does for you, and I don't think an additional tarsorrhaphy is that important in that particular setting.
Thank you. We have another question. Over the past 5 years, how has your technique or approach evolved, or what is the most important thing you have learned in doing a blepharoplasty?
That's a great question. So, I did my fellowship with Dr. Mark Codner, and, I learned how to do the skin muscle flap technique, and this is pretty much what I did, the first, 3 or 4 years. Right now, I really do different techniques, different blepharoplasty, depending on the patient. And, the skin muscle flap technique is a great technique. And, the results are usually, some of my best results, really. The problem with the technique is that, specifically in patients who have unfavorable anatomy, like, negative vector lower lid laxity, they don't have that much support, to their lower lid, or volume deficiency, or they have prominent eyes. That surgery, if it's not done correctly, can be fraught with complications, because obviously it's more kind of aggressive surgery. Younger patients who don't have any anterior lamellar problems or laxity, like they don't have muscle laxity, they don't have, a skin excess, typically I would do a transconj approach. And patients who have muscle laxity, so advanced, you can see the V-sign deformity where you would benefit from an extended blepharoplasty. Then I prefer the skin muscle flap technique. I have a combined transconjunctival approach with a skin only technique. However, that technique also works. I just don't feel that the skin muscle interface heal as well, especially if you do extensive skin only undermining. And typically you get a smoother look if you elevate or tighten the muscle and kind of excise or trim smaller amount of skin. There are situations where patients, don't have any fat bag whatsoever. In that situation, you really don't need to do anything with the fat. So you don't need to do a transconj approach or a skin muscle flap. All what you need to do is elevate the skin, tighten the muscle, and trim the skin. So that's going to, how I basically use just different techniques depending on the, presenting features and the patient anatomy as well.
Okay, we have our questions rolling in, which is great. So I'm not going to announce the question asker unless you want me to. I'll just kind of keep it anonymous because they're coming to me. Some of them are private, but I'll just kind of announce the questions as they come. So what is your experience regarding long-term durability of a simple lateral canthal suspension suture through the upper eyelid or retinacular suspension compared with a traditional lateral canthopexy for lower lid positioning?
Okay. So, lateral canthopexy is not really meant to be a permanent stitch, at least in my experience. The main purpose of a lateral canthopexy is really to splint that lid and suspend that lid while the healing process is taking place. It doesn't take that much to pull that lower lid down, even edema or, the little bit of scarring. So lateral canthopexy to kind of change the lateral canthal shape or kind of reposition the lower lid, I don't think that's the case. Now, lateral canthoplasty, on the other hand, can, change the lateral canthal, appearance. And that's what we kind of use with lid laxity. It's more of a lid tightening procedure. That's how I think about it. Many times, even when you do a lid shortening and you tighten the lid, with time, that lid still kind of relaxes with time, and it's very hard to get this kind of very crisp and pristine almond shape, lower lid with blepharoplasty, and someone who starts with bone with the lower lid or has a lax lower lid. So basically, again, canthopexy, I don't think it's a permanent stitch.
Okay. And I have a question that was emailed to us earlier today. The question asker wants to know just kind of the festooning and how that is different from the other terms that we use for either malar bag or fat herniation. And so I think in the literature, there seems to be a little bit of ambiguity with that term. And so this question asker wanted to see, they were seeking clarification, in other words. So
a malar bag is a malar bag. My understanding of the festooning is that when you have that just, excess skin that hangs over that malar area, it's basically almost like ballooning of that skin that kind of takes place specifically over the malar skin and just kind of hang. So that's what I festooning. The treatment is, with malar bags, and it's a difficult problem to treat. Different ways, both surgical and non-surgical. The surgical, you're gonna do either an extended blepharoplasty or a mid-cheek lift with through a subperiosteal plane, or you can do an extended blepharoplasty as well, and that sometimes can help. If you release the orbicularis enough and suspend the orbicularis, you'll get some correction in the malar bag. As far as the festoon is concerned, it's depending on the degree of skin laxity or how much skin is hanging, and sometimes you really need to do a direct excision to get rid of that extra skin.
I know some people might be afraid of doing that direct excision to get rid of the extra skin for a festoon. Can you speak to a little bit about the technique and how that heals? Because that means essentially an external scar that could potentially be visible.
It does. I mean, the problem is, depending on the degree and the severity of the festoon, you can, start with, the mid-face or mid-cheek lift, or letting the patient know that you're probably not going to get complete correction. And again, it depends on the severity of it. However, the scar usually heals, very well. And, I probably, it's not something that I face all the time. I've probably done it once before. And, typically, the trade-off, I guess, usually looks overall better than, what it looked like pre-op. How do you design the incision? I just do like a curvilinear incision, immediately over that area, and obviously very conservative skin excision. And that's the key.
Are there any patients that you would not do a direct excisions? For example, if they have a higher Fitzpatrick type, or if their snapback test is really, really slow, do you have any criteria for exclusion?
Well, yes. I mean, if, the higher Fitzpatrick, for example, if a Fitzpatrick, 6, for example, 5 or 6, would probably be reluctant. I'd also be, reluctant to do this on, patients that tend to do to have worse scars, or hyperpigmented scars. So basically, African American Asians probably would avoid direct excision in that patient population.
And actually, the same question asker from previous, they wanted to know just any takeaway points when you're dealing with an Asian eyelid. So do you have any pointers or any kind of pearls of wisdom that you can give to people who are tuning in to deal with the Asian eyelid?
Sure. So I don't really do that many Asian eyelids. I remember that I guess the question was mainly about the open sky technique and how do you modify that for Asian blepharoplasty.
Yeah.
The orbital septum, I mean, this is really what the major difference is. So the orbital septum in the Asian upper lids, is thick, and it goes all the way down to the upper border of the tarsal plate, and sometimes it actually goes beyond that. So when you're actually doing your open sky technique described by Dr. McCord, as you're cutting the skin, the muscle, and the septum, you will still have some residual septum. So you're not looking at the levator aponeurosis at this point, and you're going to make sure that you are removing that extra septum and you're exposing the levator aponeurosis completely, obviously. And after that, that's when you do your crease stitch. So you either go skin to aponeurosis to skin, you can go skin muscle to aponeurosis to muscle skin, or you can do skin to the upper border of the tarsal plate to skin. I mean, so there's just different techniques that have been, described, and that's basically the difference. Or that's how you modify your upper lid open sky technique in the Asian population.
Dr. Alghoul, I've got a question just in from Dr. Nahai, who's on the line.
Yes.
He says a lot of surgeons shy away from skin muscle flap for fear of lid retraction. What has been your experience?
Well, my experience has been with skin muscle flap technique. I think that the procedure, compared to a transconj, probably does have a higher rate of retraction, but it's also all technique dependent. And it also depends on, the patient anatomy. So if you do a skin muscle flap technique on someone who has a negative vector and you don't overcorrect with your lateral canthopexy, you may end up with some retraction. So I think the technique can be unforgiving sometimes if it's not done correctly. So when you're doing it, you're going to have to do it meticulously, make sure, there's no bleeding, there's no bruising, you're going to try to minimize scarring as much as possible. You're going to follow up these patients. I mean, I see my patients pretty much, on the first week, the second week, the fourth week, and the 8th week. And the reason why I see them, because I want to make sure that as the scar is developing, that I'm there and trying to support that lid either with injection or with Steri-strips, with massaging. So basically pretty aggressive about preventing a problem. Now, patients who also have some lower lid laxity, they'll be at risk as well. So skin muscle flap, I think, is a more aggressive procedure compared to a transconj approach. However, when it's done correctly, you can get beautiful results. And maybe slightly higher risk of retraction, but it's not prohibitive of actually adopting the procedure and kind of offering it to patients.
And Dr. Nahai, you've been unmuted if you wanted to chime in. Sorry to put you on the spot, but did you have a response?
Can you hear me?
Yes.
Yes.
Just wanted to congratulate Mo, and you've done a great job. I couldn't agree with you more that some of the best results are with the skin muscle flap, but unfortunately, many surgeons shy away from it, and unfortunately in our literature, the number of 20% risk of lid retraction is always quoted, whereas frankly, in experienced hands like yours and some other published data, it's closer to 1%, 5% if it's a secondary blepharoplasty. So just wanted to thank you for a great article and a great discussion this evening.
Thank you, Dr. Nahai. It's great to hear your voice tonight.
And I think we have a minute or two left. Cindy, should we unmute everyone and see if anyone wants to jump in with a final question or two?
Yeah, let's do it. Oh, one just came in, but yeah, let's go ahead and unmute everybody. Do you release the orbital malar ligament on all of your lower lid blepharoplasty procedures?
This is a great question. I do not. So the only reason you would release the orbital malar ligament, in my mind, there are two reasons, right? The first reason is if you want to redrape the fat across, and the second reason, if you want to suspend the orbicularis. You cannot really do an orbicularis suspension unless you release the entire orbicularis retaining ligament. You cannot redrape the fat across the rim unless you release the orbicularis retaining ligament. Now, keep in mind, the orbicularis retaining ligament is a stabilizing structure of the lower eyelid. That's what the retaining ligaments do. They basically stabilize the soft tissue, and it's stabilizing the soft tissue here to bone. And this is why, if you don't really need to release it, you don't have to release it. So, for example, if a younger patient presents with a tear trough just medially with like a central and medial fat bag herniation, you can do a transconj approach, release the orbicularis retaining ligament or tear trough ligament just in that segment and just redrape the fat across. You don't really need to release the ligament all the way towards the lateral canthus. Does that answer the question? Having said that, I tend to release the orbicularis retaining ligament on a lot of my cases because I do orbicularis suspension and I do redrape the fat across the entire area most of the time.
So are there any other questions from the audience? People who want to jump in for the last minute? Yes, Dr. Alghoul.
My question is, how do you deal with a patient that feels that all their problems in the periorbital region can be addressed with botulinum toxin and fillers alone without surgery?
If I hear you correctly, if they feel that all their problem can be dealt with what? I'm sorry, with filler or toxin?
Yes.
Okay. So, I mean, yes, obviously you always, I just saw a patient yesterday who, she's your classic surgical patient, and she's here because she saw me because she wanted, filler. So I basically tell them that I would not recommend the filler treatment, and I basically won't do a filler treatment on someone who has, you know, for example, excess skin or really, you know, severe signs of aging. So, you know, most of the time I think toxins help a lot. And the reason why, you know, Botox or toxins help significantly, especially in the lateral orbital area, because it tends just to open up that area, and you get, you know, less hooding. Probably you'll be surprised how much tightening and correction you can get in that area. But most of the time, obviously, the surgical patient is going to have to, you know, basically stick to a recommendation. I mean, they get surgery. I typically. I like to do surgery to correct the lower lid, especially the medial aspect of the lower lid, because that's when you get really your best results. And even with filler treatment, you know, many times you can just spot that. You can just tell that someone had a filler treatment, and it's just unforgiving. And if you just put slightly more than you need to, you know, you convert a groove into a bulge, and it just looks completely unnatural. Now, having said that, I think there's a great role for using fillers in the lateral aspect. So, you know, if you remember that first slide that I showed, that we're showing today, there's this lateral C-shaped fullness that goes from the lateral brow all the way to the lateral cheek. That's a great area for filler treatment. But you know, someone with a surgical candidate just gonna, you know, tell them that just they need surgery.
Yeah. Well, I want to thank everybody for participating tonight. I think it was a great discussion. Thank you, Dr. Alghoul, for your time and your expertise. I'm sure we all appreciated reading your article and asking you questions. And I want to tell everyone that this will be recorded in case you want to review. We will have these live journal clubs now every month, and we alternate with YAPS to host the journal clubs. So it'll be the first Tuesday of every month at 8 p.m. Eastern Standard Time. So thank you, everybody, for joining in today.
And don't forget to take the CME test on Dr. Alghoul's article for credits.
That's right.